Welcome to Rolf Sport and Health for a presentation on low carbohydrate, high fat nutrition with specific reference this evening to the topic of diabetes. I've given many of these talks over the last 2 years, and many of them to do with low carb nutrition and weight loss. And we've also done heart disease. And what we thought we'd do this evening, and we're going to continue this trend, is to refine this talk down to more specific topics. It means we can be a bit more tailored, and also they end up a lot shorter than when we try and do weight loss, diabetes, heart disease, and everything else in one talk, and we leave here at 5 to 11, which is always interesting but tiring. So on behalf of all the Rolf Valley structures, the gym, the Sports Medicine Center, and our Weight-Lite program, which I'll say something about just now, we welcome you. I want to start advertising the fact that I've written a book called The Low Carb Companion, and it's hopefully going to come out in August. So I've basically spent the last year summarizing all the latest research in low carbohydrate nutrition with respect to health and disease, and also for exercising athletes. So that'll come out soon, and that might be of interest to some of you when it comes out, and we'll certainly let you know by email when it's around. We run a program here at the Sports Medicine Center called the Weight-Lite program, which was started about 3 years ago, specifically with reference to assisting people to do an effective low-carbohydrate program, specifically with regard to losing weight. And that has been quite successful, and just recently we have started to venture into having a go with type 2 diabetics who are not too clinically challenged, and we see that extending going forward because low carbohydrate nutrition as a treatment intervention is becoming increasingly important in modern medicine. So if you have any interest, Linda's the lady you met at reception. She's walking across the gym there now, and I've put her cell number also on the dry wipe board. So let's talk about diabetes. So I'd like to know your interests. Is anyone here a diabetic? Type 1, type 2. Okay. The talk is mostly about type 2s, but I'm going to say a few things about type 1s later, and you must ask me some questions because there is some relevance to you recently. You're a type 2. Yeah. Anyone else? Type 2s. All right, all type 2s. Most people are. He's a type 2. Okay. Where's he? Oh, okay, excellent. Well done for coming. Well, the bottom line is you can see from the slide, there are 2 major types of diabetes. There is type 2 diabetes, so-called, and type 1. But by far the most common type of diabetes is type 2. It accounts for 90 to 95% of all cases of diabetes in the world. So type 1 diabetics are generally in the minority. In the old days, we used to call this maturity onset diabetes or non-insulin dependent diabetes, but those terms have faded away because they're not particularly relevant or accurate. And we used to call this juvenile onset diabetes or insulin dependent diabetes, and again, those are old terms and they are no longer used because their relevance has also faded. So we talk about type 2 and type 1. There is a third type of diabetes, which is called gestational diabetes, which occurs in pregnant women during pregnancy. And it is a slightly separate type of diabetes because of the unique situation of pregnancy in which it exists, but it is in fact a form of type 2 diabetes. So in reality, gestational diabetes is type 2 diabetes that occurs specifically in pregnancy and provoked by pregnancy. And a large number of women who develop diabetes in pregnancy will go on to continue to be type 2 diabetics, about 80%. So developing diabetes in pregnancy is not a good thing, because you're very, very likely to continue to have this disease later on in life. So much of what I have to say this evening is relevant to type 2 diabetes, and I will talk a little bit about type 1 at the end. So type 2 diabetes, conventionally, in all the years that I have been a doctor, which is 30 of them, the way I was taught and the way much of modern textbooks are still written, but there is an evolution in process. The convention is that type 2 diabetes, we have been told, is a chronic disease. Once you have it, you have it. It's not a curable disease, but we can manage it using diet and drugs. And that's the way I was taught. That's the way I've practiced medicine in the field of diabetes for the best part of 30 years. Bottom line is, much of that we have got wrong. And we've only kind of figured that out quite recently, and it is starting to change the way that people think, and there are some thought leaders in medicine who are changing this, but it's certainly not mainstream yet that we are in change. These are the new truths about type 2 diabetes. It is a curable disease. It is a curable disease. Secondly, diet is the cure. So medical therapy, drugs are not the cure for diabetes. Diet is the cure. It's a big problem. There are currently in the region of 387 million people worldwide suffering type 2 diabetes. By 2035, it's expected to increase by another 205 million people at the current rate of world increase. Where are most of them located? Well, most of them are interestingly in the Pacific Rim. But Africa has got a good 60 million diabetics. If we look at the projected increase from 2013 to 2035 up to 592 million people, that's a 55% increase projected over the next 2 decades. The reason I'm showing you this slide is that the biggest increase is projected to be in Africa. Africa's diabetic rates are projected to increase by more than 100% in the next 20 years. So that's lots of people with diabetes. That's a big problem because at the moment 1 in 12 people have diabetes. Half of them don't know they have it. Every 7 seconds someone dies of diabetes, and in current world health spending, $1.09 is spent on the treatment of diabetes. And if you look at those projected increases, that's going to become more and more. If you look at the worldwide prevalence just on a simple graph, you'll notice that from 1985, it's just going up a lot. That means for people like me, there's lots of work, so I'm happy. I'm not getting unemployed if diabetes carries on. There'll be lots of work for doctors and dietitians, but we would like that work to go down. I love this cartoon. Diabetes has increased dramatically over the past 10 years, therefore it must be caused by global warming. No, it's not. Okay. Because if you look at global warming, that's kind of the same graph that you'll see. These are American figures, and the reason I'm showing you that is you'll notice that around about, well, these are diabetic rates, started to creep up after 1980, creep up, and then 2000, 2005 started to go up dramatically, and that's the projected exponential increase in American diabetic cases. And America's got lots of diabetics, about 90-odd million. So the question that has to be asked is, what happened somewhere around about there in 1980? Because type 2 diabetes is a disease that befalls individuals around about 10 to 20 years after things start to change in their metabolism. The disease onset in most is about 10 or 20 years later. So effectively, if you actually look at the graph pre-1980, it was pretty steady for about 20 years, very little increment. So from the 60s to the 70s wasn't much different to the 1980, and then started to go up. So what changed? Anybody know what changed in 1980? Zimbabwe became independent. You missed that one. No, it wasn't our fault. We are not the ones. Okay? Our sugar is a good statement. The reality is that in 1980, the Americans published the first World or Food Guidelines Pyramid. And that has been continued with minor modifications right up to today. And the new one is coming out in December this year with some, I think, significant changes, which are long overdue. But this pyramid effectively, and you don't need to look at it in detail, told us that 60% of our calories from 1980 should be taken in the form of carbohydrate foods. And the reason that this was suggested was because in the 1960s and 70s, we developed a phobia of fat and cholesterol in terms of its relationship to heart disease. So in order to run away from fat and heart disease, the advocacy was for us to eat increasing amounts of carbohydrates. So the American population and much of the world over the last 30 to 40 years have been eating according to this food pyramid. And things have changed. So if you look at the evolution of man, For much of 2.5 million years, we were hunter-gatherers. Only in the last 12,000 years did we start growing things in the ground and harvesting wild grasses into agricultural grains. That's a fairly recent time frame in human history. In the last 200 years, we developed the industrial ability to process foods, but in the last 35 years, we were convinced to eat a high-carbohydrate diet. And in that microcosm of human time, humans have changed to the greatest extent in shape and health. So what we have in the modern day is what we call the twin epidemic. That's why in the last slide I used the word diabesity. A combination of a diabetic epidemic, type 2, and an obesity epidemic that have run hand in hand from the early 90s. Including children in much of the first world, obesity rates in children in the first world are, quite frankly, horrific. In fact, the US estimates that 1 in 3 children born since 2000 will develop diabetes in their lifetime. 1 in 3. That's the current projection. If you drink soft drinks, for every soft drink that you drink per day, your risk of diabetes increases 25%. You mentioned the word sugar, sir. Lots of sugar in soft drinks. How much sugar in a can of the average soft drink? Coca-Cola or any of those? Any ideas? A 330 ml can, your standard can. 7 teaspoons, like an auction. So, madam, thank you for putting your first bid on the table. So I've got 7, I'm going to be 8, 8, 8, I'm going to be 8.5. Any other offers on the table? 9.5, Mrs. Broderick, 9.5, 9.5, still going. So any increments on 9.5? 10, 10, 10, 10 going once? 10.5. 10.5 teaspoons of sugar in a single can of the average fizzy drink. If, however, you like Fanta grape, we can go up to 12. Okay, just in case that was your favorite drink, it's time to unfavorite it. Right, so we have probably almost a third of most people's diets in the first world, their carbohydrate intake is in the form of fizzy drinks. Okay, the average American teenager drink between 1 and 2 fizzy drinks a day. It's the standard, it's the norm, so there's a large intake of sugar and carbohydrates. The other thing we know is that there is a strong genetic trend in populations, probably up to 65, even 70%, of what we're now talking or calling carbohydrate resistance. That means a form of carbohydrate intolerance. It says that people who have these genetics are much more likely to fatten if they eat a lot of carbohydrate, especially refined sugar and carbohydrate. So we call that carbohydrate resistance or carbohydrate intolerant. And that's a strong genetic trend in up to 60 to 70% of people in any population studied so far. And that would explain the type of obesity figures that the first world are seeing. In America, up to 75% of the population are currently overweight or obese. 75%. Which is staggering. Sorry? It's not a fizzy sweetened drink, but we'll talk about beer. The other staggering and frightening thing about diabetes is the cost of treating it. In America, which is probably one of the most expensive medical countries in the world from a treatment point of view, the average cost of treating a 50-year-old type 2 diabetic who dies 8 years prematurely because of his diabetes will amount to somewhere between $150,000 and $250,000 US in direct and indirect health costs. Okay, that's not relative to Zimbabwe, but it gives you some idea that this is a very expensive disease over the tenure that people will suffer it. And if you're someone who's looking at public health, who's looking at public health expenditure, who's looking at the budget for your country, and you have a look at the millions of diabetics that currently exist and the exponential increase that is projected for the next 20 years, I'd be very afraid if I was someone in charge of a nation's economy. I wouldn't be worried about conflicts around the world. I'd be worried about my nation's economy collapsing in the next 15 to 20 years under the burden of diabetes. So it has a staggering and frightening health aspect as well. What are the risk factors for type 2 diabetes? Well, one is having a family history, which boils down to that genetic profile of being carbohydrate resistant or intolerant, or having a family history where there are family members who frankly have type 2 diabetes. So if you've got family members with type 2 diabetes, you have a very good chance of developing that disease under the right circumstances. Obesity is a risk factor. 80% of type 2 diabetics are by measurement standards obese. So that's a very strong association. Diabetes takes time to evolve. So most diabetics, 70% of diabetics, will be 50 years and over, but there is an increasing incidence of diabetes in young people now with the epidemic of obesity, which is afflicting people younger and younger. So the younger you develop obesity, the more likely you are to develop young onset diabetes as well. The presence of metabolic syndrome, which is what we also call prediabetes, which is very overweight, high blood sugars, high insulins, high blood pressure, abnormal cholesterol, but not sugars enough to quantify you to be diabetic, is called prediabetes or metabolic syndrome. And 75% of people with prediabetes will go on to develop full-blown type 2 diabetes. I mentioned gestational diabetes. 80% of pregnant women who develop diabetes in pregnancy will go on to develop full-blown diabetes. If you happen to be born of a mother who is obese or develops gestational diabetes during the pregnancy in which you are in the uterus, you have a very good chance also of becoming a type 2 diabetic. So the risks will be inserted, if you like, in utero. Okay, the risk will be there as a consequence of that environment in which the baby is nurtured. A diet that is high in sugar and refined carbohydrates, and I've made the point about fizzy drinks, is a high risk factor. A lack of physical exercise is a high risk factor. And certain medications, including statins and diuretics and steroids, these types of medications also increase your risk of becoming a diabetic. And there are others. Why is diabetes such a dreadful disease? It's a dreadful disease because it has very significant complications. First of all, it's very likely to produce premature death. People will die from the complications of diabetes 8 to 10 years before their chronological predicted time. So that's not a good thing. But 70% of diabetics will develop cardiovascular disease, most notably heart disease, and have a heart attack. So 70% of diabetics are very likely to die prematurely from a heart attack. Or they will stroke, or they will develop circulatory disease in their limbs and have their limbs amputated. These are dreadful conditions. It is a disease of accelerated aging of the bodily tissues, closely associated with high blood pressure, kidney disease, an increased risk of cancer, especially of the breast and of the colon and the prostate. Nerve damage, infections, terrible foot ulcers, blindness, premature death I mentioned, and an increased risk of Alzheimer's. So diabetics have double the risk of developing Alzheimer's. There's a very close association between the risk factors for diabetes and the risk factors for Alzheimer's. There was an article in a journal a year or two ago with a suggestion that Alzheimer's should be renamed diabetes type 3 because of its close association with type 2 diabetes. So I want to just take you very quickly through what we now really understand is the evolution of type 2 diabetes. How do you develop type 2 diabetes? Well, first of all, you need to have those genetics that increase your intolerance to carbohydrates. And as a genetically carb-resistant individual, you eat a high sugar, high refined diet for a number of years. You will start to develop fluctuant elevated blood sugars. In response to that, your pancreas will work hard and produce extra insulin to handle those blood sugars and all that carbohydrate that's coming in, and you will start to suffer from persistent high levels of insulin in your body. At this point in time, and I told you in that one slide, 1 in 2 diabetics won't know they've had it, and people are not necessarily sick or aware that they have these problems. but their metabolism is not happy. High blood sugars and high insulin are abnormal metabolism. Then there's an inflammatory response that develops in the body as part of this high sugar, high insulin environment. And increasingly, tissues in the body start to become resistant to the effects of insulin. And resistance is a form of deafness. You understand deafness? So when you start to go deaf and you're listening to the radio, everyone has to come and turn the volume up. If tissues are becoming resistant to the effect of insulin, which we're going to look at just now, then they're not hearing insulin, so they don't respond, they don't listen. Okay? We'll examine insulin resistance in a moment. Once you become insulin resistant, and my thing don't want to work, you start to gain weight, and you get fatter and fatter, especially around the middle. So central obesity. Then a large number of people will develop metabolic syndrome, which I mentioned. In addition to being overweight, they'll be hypertensive, they'll have the high blood sugars, the high insulins, but they won't yet be diabetic. And if you carry on eating a high carbohydrate diet, then a large percentage of people will develop full-blown type 2 diabetes. This is the progression of diabetes. This is the evolution of diabetes in an individual. And then the longer they have their diabetes, they will progress to diabetic complications, which I've shown you. There are lots of them. They're nasty. Most of them involve arteries. Very simply, if we want to do a very quick biology lesson, insulin has many, many actions in the human body, but it has two very important actions. One is it controls the entry of sugar or glucose into our cells. Without insulin, sugar cannot get into cells. It's the gatekeeper. Does that make sense? All right, so when there's sugar in your blood, which has come from the carbohydrates that you've eaten, in order for that sugar to move from the blood into cells, you need insulin to open the door. One of the other very important actions that people don't often know is that it's also very important in controlling your fat stores. Insulin is also the gatekeeper for your fat stores. It opens your fat stores and puts fat in and then locks the door. So if insulin levels are high, it facilitates the storage of fat, but it also locks the door. Okay, so it promotes the storage of fat. Insulin is obesogenic. It promotes fatness. Okay. So if you understand those things, then the rest of it will be easy. We're happy with that. Okay, you probably knew those things already. Okay, so here is a normal, non-diabetic individual who's eating breakfast, lunch, and supper. And there's carbohydrate in those meals, as there are in most people's meals. We will see in response to that a blip in their blood sugar as they absorb that carbohydrate from their diet at breakfast and at lunch and supper. And in response to that, their pancreas will secrete the requisite amount of insulin to manage that blood sugar. Happy? Simple. Okay. Now let's contrast this with someone who has carbohydrate resistance, the carbohydrate intolerant person. So this is the carbohydrate intolerant person now eating their 3 meals and possibly more. What happens with them? They absorb the carbohydrate and they have these peaks of blood sugar in response to the meal, but the amount of insulin that they produce is much more. So carbohydrate resistant people have an exaggerated insulin response. And as their cells become more and more insulin resistant, so too does this insulin response become more and more exaggerated. If the cells aren't, what do you do if granny can't hear the TV? What do? You turn it up. So if your cells aren't hearing the insulin, your pancreas turns it up. So you see increasing levels of insulin circulating in the bloodstream of a carbohydrate-resistant person who is insulin-resistant. Have you got this biology? It's not too complicated. Unfortunately, though, especially when we're eating a high-carbohydrate diet, we're usually hungry a little bit more frequently than breakfast, lunch, and supper. Is that true? All right, so either because you're hungry or because somebody once told you that you should snack 5 times a day, keep yourself fueled up. In fact, we have insulin spikes which are elevated in between. Nighttime, little snack. Isn't it between breakfast and lunch, we've got to have some tea and biscuits. In the afternoon, we need a little bit more tea and some more biscuits and cake. So that's generally the profile of someone who's eating a lot of carbohydrate. And in someone who's carbohydrate resistant and insulin resistant, eating a lot of carbohydrate, they're having frequent high levels of insulin, persistent high levels of insulin. Right, this is a very important concept. So, let's have a look at a little bit of biology. We eat a high carbohydrate meal. All carbohydrates are broken down into what? Predominantly sugar, and there are two major sugars in our food. One is glucose and the other one is fructose or fructose. So table sugar that you put in your tea is half glucose and half fructose. And most of the sugar that's added to food to make it taste nice is either sucrose, table sugar, glucose fructose, or something called high fructose corn syrup, glucose fructose. It's glucose and fructose when it gets into your bloodstream. Yeah, boy? Right, so here we are. We ate a yummy donut. Does that make you feel hungry tonight? Yummy donut. Blood glucose will go up, yes. In response to that, your pancreas will produce insulin. And if you're a carbohydrate-resistant person, it will produce quite a lot of insulin. What's the effect of that insulin? What's it trying to do? It's trying to take that blood glucose and put it into your two biggest storage areas for sugar in the body, which are your liver and your muscles. That's where you want to put the sugar. All your cells will be looking for some sugar, but the best place to store it away are your liver and your muscles. So that's what insulin is trying to do. The problem, though, when you become insulin resistant, is that those are the two tissues that become the most deaf to the effects of insulin. They don't listen. Insulin is knocking on the door saying, excuse me, please, there's some sugar here in the blood, it needs to come in. And they're going, what? So the potential storage for that glucose in those two cupboards is significantly reduced. So if you can't take that elevated glucose and put it into the cupboard, what's happening to your blood sugar? Is it going down? It's staying up. And your body doesn't want an elevated blood sugar. That's not a healthy state of affairs. So insulin then has a default position. If it cannot take that high elevated blood sugar and store it away in the quantities it needs to bring blood sugar down to a normal level, then it dials up your liver on another telephone line and it says, right, if you're not going to store this sugar, then you must convert this sugar into fat. And that's exactly what your liver does. Your liver takes glucose and it converts it into fat inside the liver. And it's a very efficient mechanism. And then once that fat has been manufactured, it has to be stored somewhere. So we store it in two places. We store it in our livers, and we store it in some very useful expandable containers that we have predominantly in the abdominal area. So we start to convert more and more of this incoming sugar into fat, and we get fatter. And what did I say about insulin? It promotes the fat storage, and it locks it up. So insulin is great for fattening and no good for thinning, because it wants you to keep the fat in store. The other downside to this is that fructose, which is the other sugar that comes into the bloodstream from carbohydrates, cannot be metabolized in any other way than the conversion to fat. We don't burn fructose for energy, which we do a lot of the glucose. We can't do anything with fructose, and yet it constitutes up to half of the incoming sugar from all food that we eat. And we can do diddly squat with it other than convert it to fat. So fructose is a major role player in the fattening process that is associated with the intake of carbohydrate foods, especially when you are carbohydrate resistant or diabetic. So effectively, we don't get fat because we eat lots of calories only. It's not just about calories. It's actually what we eat, if we're eating that sort of food, and how frequently we eat, spiking our insulin, And then what our body does with what we eat, does it convert that carbohydrate into fat or does it burn it for energy? That determines whether we're going to get fat and develop diabetes. You with me? Okay. So it's not just about, oh, we ate too many calories and there was some left over, so we stored it away. That's a very simplistic biological model that has no plausibility in the metabolism of human biology. Doesn't compute. It's about the metabolic interactions between carbohydrate, sugar, insulin, and fat production and storage. So let's go back to diabetes. I want to explain the disease to you, because if I asked you, you'd probably say the disease is high blood sugars. Would that be right? If I said to you guys, what do you think the disease in diabetes is? Would you say it's high blood sugars? It's most people's generic understanding. Yeah? It's a disease of elevated blood sugar. You're shaking your heads because you're cleverer than me. Okay. All right, if I ask 90% of people what is diabetes, I'll say it's a disease of elevated blood sugar. And what I'm going to say to you is it's not. It's a disease of insulin resistance. The magic word in diabetes is insulin. All right? Because when we have those carbohydrates and we have those elevated blood sugars, we have elevated insulin, as I showed you, and especially persistent, frequently elevated insulin. And that then leads to these tissues, muscles and liver, becoming increasingly insulin resistant. And as we become more insulin resistant, our pancreas has to pump out some more insulin. So we have a compensatory increase in the circulating insulin. So the disease of diabetes is a repetitive cycle of insulin metabolism. We have too much insulin as a direct consequence of having increasing insulin resistance. And insulin resistance starts 10 years, if not more, before you develop diabetes. Insulin resistance is the disorder that develops when we have carbohydrate-resistant genetics. We eat too many carbohydrates, sugar and refined, and we develop insulin resistance 10 to 20 years before we develop diabetes. This is the fundamental metabolic disorder, and it is also the disease. It is not a disease of sugar elevation. So the disease is insulin resistance. And we have insulin resistance because we have persistent elevated insulin levels as a direct consequence of how much sugar and refined carbohydrates we are eating 5 or 6 times a day. And this is the new paradigm understanding of diabetes. And you guys are very lucky because you're one of the few audiences in the world who've ever heard this. I was lucky to be at the World Conference that took place in Cape Town in February in nutrition, and a real thought leader from Canada, a diabetic physician called Jason Fung, gave us the new paradigm for diabetes, and it's new. But it has reformatted our understanding of the disease and how to manage it. And hence, we are reformatting that paradigm that it's not a chronic disease, it's a curable disease, because we understand it a bit better, a lot better. So insulin resistance is the disease, and the symptom of diabetes is having high blood sugars. That's the symptom. It's not the disease. Type 1. They don't have any insulin. Type 1 diabetics have a pancreas that has failed them for various reasons, autoimmune diseases, maybe an infection. They don't produce any insulin. Therefore, when they eat carbohydrate, they have no insulin to manage it. Don't get me wrong, we all need insulin. It's a vital metabolic hormone. But when this cycle of high sugar, high insulin, insulin resistance, and compensatory elevated insulin is in place, that becomes an abnormal metabolism. We all need insulin. If we didn't have insulin, we'd die. So type 1 diabetic without insulin will die. They eat carbohydrate, they'll go into what's called ketosis or ketoacidosis, and they will die quite quickly. Okay, so we need insulin. But we don't need insulin doing what I've been showing you on this green cycle. Does that make sense? We'll talk about type 1s. Type 2s are not insulin deficient. They've got plenty of insulin, too much insulin, because the insulin resistance is causing their pancreas to pump out more and more and more. So the disease is insulin resistance. The type 1 diabetic, their problem is insulin deficiency. Okay. Very different, but I'm going to show you just now, it almost comes back to meeting at the end of the day. So once you've got elevated insulin, in this new paradigm, we now believe that we suffer from insulin toxicity. When we have excessive insulin around the body, it's now toxic to the body in many ways. And these effects are the filling up of the liver with fat, which interestingly makes insulin resistance even worse. Filling the body up with fat, becoming obese. Our kidneys, under the influence of excess insulin, retain salt in water, and our sympathetic excitatory nervous system becomes overactive, and the two consequences of retaining sodium and having a lot of adrenaline going around your system is that your blood pressure goes up. That is why hypertension is so closely associated with diabetes. It's a direct consequence of the metabolic effects of insulin. Our cholesterols become what we call atherogenic. That means unfriendly to heart arteries, very likely to induce atherosclerosis, coronary artery disease, and heart attacks. That's an insulin-mediated effect among other factors. Therefore, heart disease is a direct result of insulin toxicity, and the risks of cancer, which I attributed to diabetes, are a direct result of insulin toxicity. High insulin levels facilitate cancer growth because they allow cancer cells to gobble up more sugar. Okay, I gave a lecture on that a couple of weeks ago. The elevated glucose levels and indeed fructose levels also are toxic to the human body. So we talk about glucotoxicity. That's what causes premature aging, also contributes to the fat production, damages the eyes, causing blindness, causes arterial inflammation and damage along with insulin, damages nerves, damages the brain, Alzheimer's, also upsets the cholesterol profiles, and contributes significantly to heart disease and to the increased risk of cancer. So you have this dual toxicity going on in diabetics, insulin toxicity and glucotoxicity, causing the complications of diabetes. So, currently, what are the problems in the way that we manage type 2 diabetes conventionally? Conventionally, we put diabetics on a low-carbohydrate diet, but we allow them to eat 120 to 150 grams of carbohydrate in that diet, in conventional dietary regimens for diabetics. Why did we ever do that? What's the fundamental disease in diabetes? What's the disease? Insulin resistance. Thank you, sir. What causes insulin resistance? High levels of insulin. High levels of insulin. What causes high levels of insulin? High levels of sugar. And yet we feed diabetics 150 grams, which I'll tell you is a substantial amount of carbohydrate a day, because we are afraid of fat causing them heart disease. I have just shown you that heart disease in diabetics has got nothing to do with the fat they take. It's to do with the sugar and the insulin that is toxic to their arterial systems, and the high levels of inflammation that coexist with diabetes. It's not about fat intake. And there's a whole lecture, and I gave that recently as well, on cholesterol and heart disease, and saturated fat and heart disease, and that science is changing dramatically now. Saturated fat has got nothing to do with heart disease. And in December this year, when they bring the new food guidelines out, dietary cholesterol is being removed as a risk factor for heart disease. Dietary cholesterol is not a risk factor for heart disease. It's coming out in December. So that might wake you up a little bit. Okay, so there's going to be substantial changes. So we allow this because we have a fear of fat, yet fat's got nothing to do with heart disease. So why are we feeding diabetics all this carbohydrate, which is definitely maintaining their state of diabetes? If you feed someone whose primary problem is insulin resistance, which is caused by high insulin, which is caused by an intake of carbohydrates, you feed them carbohydrates, you are maintaining their state of diabetes. Then what we do is, because we have this problem with blood sugars, is that we use initially diet, which usually fails after a while. Then we move on to oral drugs. There's all sorts of oral anti-diabetic drugs. Metformin is a very common one. Glibenclamide is another common one. And these drugs help to reduce the blood sugars. But if you actually track type 2 diabetics as a population, most of them progress from diet, but a few years later, they have to use drugs. Then a few years later, they have to use some insulin because their tissues are so insulin resistant that they can't produce enough to make the tissues listen, so we've got to give them some more. And if you track them for a few more years, they just simply have to use more and more insulin. What we have realized is if you follow this process, what do we understand? That diabetes in type 2 diabetics is continuing, but we are supposedly treating them. We are treating their blood sugars. We are not treating their diabetes. Blood sugar is a symptom of diabetes. Insulin resistance is the disease itself. If we want to remove insulin resistance, we must reduce what? The insulin. Treating a disease which is caused by insulin with more insulin is the same as treating alcoholism with alcohol. Funny enough, it doesn't work. And this is the progression in diabetes that we have observed for 25 years, and for some reason we just keep on doing the same thing. And Albert Einstein once had a famous quote about doing the same thing. You know that quote? If you do the same thing over and over again and expect a different result, that is the very definition of insanity. Okay. So treating diabetes this way, to be honest, is insane. If we look at all the studies, and there's big studies, irrefutable, massive studies in diabetic management, they show very, very clearly that the complication rates of diabetes are unchanged by this conventional treatment. Despite oral drugs and despite insulin, diabetics die of the same rate of heart attacks as they did before we had any of those drugs. So when we didn't have insulin and we didn't have metformin, 70% of diabetics died of heart attacks. And now that we have those drugs and insulin, 70% of diabetics die of heart attacks. We have not changed the outcome of diabetes in 50 years. But we've been very proud of ourselves because the diabetic patients bring us their blood sugar logbook, which looks lacquer. That means very good for those who don't speak Zimbabwean. So we have, in a way, kidded ourselves that normal blood sugars are an indication that we are managing the diabetes, whilst their insulin is high, and in many patients are giving themselves insulin, which means the diabetes is progressing. And the more insulin that we give the diabetics, the higher their rate of heart disease. But you know why? Insulin causes heart disease. So it's no brainer. If you give someone more insulin, they're going to get more heart disease. So the new treatment paradigm, ladies and gentlemen, is this. The key to treating diabetes is to reduce insulin. We have to reduce the insulin in their body, whether it's what they're producing themselves or what we are giving them in addition. Diabetes is undoubtedly a dietary disease. It's caused by diet in people with a genetic predisposition to handle carbohydrates badly. And thereby, it's a curable disease by manipulating that to reduce that. We must reduce their carbohydrates to reduce their insulin to cure their diabetes. So, is what I say true? Has it been proved? Yes. If you do bariatric surgery on morbidly obese diabetics, very, very fat diabetics, there's various procedures to limit their stomach's ability and the intestine ability to absorb carbohydrate, we cure diabetes in 90% of cases. We didn't give them any drugs. We just limited their ability to absorb the carbohydrate in their food by cutting out half their stomach or putting a sleeve around their stomach so that it can't contain more than a small amount of food. And diabetes gets better in 90% of cases. So these are the first studies that showed us diabetes is actually a curable disease. But why the hell do you want to operate on someone if you can actually fix their diet and achieve the same thing? There's been some very good work with intermittent fasting, which means having 12 to 24-hour fasts, and also shown high rates, there's only small numbers in this research, of high rates of diabetic cure. But the biggest amount of research in the nutrition has been using a very low carbohydrate, what we call ketogenic diet. Very low carbohydrate ketogenic diet. And the cure rates are very high. I'll show you how high. But let me define something first. What's a reduced carbohydrate diet? Well, that's the sort of diet that we would feed the conventional dietitian's diabetic diet. So that's over 130 grams a day, but less than what most people eat, which is between 300 and 500 grams a day. So that's what we call a reduced carbohydrate diet. That's no good for a type 2 diabetic. A low carbohydrate diet is where we aim to reduce it to less than that, but with the diet I'm talking about, and I don't like the word diet, nutrition, is to reduce carbohydrates to less than 25 grams a day. That's what the thought leaders in this field have been doing. And the results of that is that you get good blood sugar control, but very importantly, you reduce the level and fluctuations of insulin. In the studies that have been done in the clinics that are doing that, you certainly reduce and in many cases eliminate their medication. A very low carbohydrate nutrition program is very effective for weight loss. It is more effective and more sustainable than a conventional low-fat diet. When you substitute fat for carbohydrate in the nutrition program, you generally see the risk markers for heart disease get better. So if you take out carbohydrate and you put fat into a nutrition program, the heart risk factors get better. I'll show you that. You see the features of those with metabolic syndrome get better. Blood pressure goes down. Interestingly enough, it goes down by substantially more than if you try and put someone on a low-salt diet. So low-salt diets don't do very much to blood pressure. They might reduce it by about 3 units. If you reduce carbohydrate, you will reduce blood pressure by up to 20 millimeters of mercury. That's treatment. 3 millimeters of mercury is tinkering. Okay, so sugar is the key, not salt. And the really interesting thing from all the research is that most of the beneficial effects when we restrict carbohydrate in a type 2 diabetic occur before they lose substantial amounts of weight. So it's not the weight loss that is driving the improvements. It's the carbohydrate restriction. And we understand why, because when you restrict the carbs, the insulin goes down. Insulin is the cause of diabetes. This gentleman, Eric Westman, is a diabetic physician at the Duke University in the United States, which is a very prominent medical school. For the last 12 years, he's been running a carbohydrate-restricted program for diabetics in their clinic. And what they've shown is that when you restrict the carbs, both the blood sugars and insulin go way down. Obviously, they do all the blood tests on these patients. They have to reduce insulin in the first 24 hours by 50% to stop these diabetic patients having hypos. 50% in 24 hours. There is no medication on earth that has ever been shown to achieve that. 95.2% of their diabetic patients over the last 12 years are either on extremely restricted medications and on very little, or they're off all by 6 months. Which by definition means that the bulk of 95.2% of their type 2 diabetics are by metabolic parameters cured. If your blood sugar is normal, if your insulin levels are normal, and you do not require medication, you are no longer by definition diabetic. Yeah? Okay. So these are fantastic, fantastic figures. So that's the key point. No more insulin. Insulin is not good for diabetes, type 2. I don't want to show you graphs, but this is just one I thought I'd show you. These are the effects of in fact, this is a 20-gram a day carbohydrate restricted program. And just looking at this is the blood glucose level. This is the low-carb nutrition against a normal diet. And this is the insulin levels. And just to show you that blood sugars go way down and blood insulins go way down. If you reduce sugar and you reduce insulin, diabetes gets better. Okay. So, the number one intervention for type 2 diabetes is to cut carbohydrate down to less than 25 grams a day and to absolutely exclude all sugar and refined carbohydrates, which by nature have the most substantial effect on insulin in the human body. The real message is to eat real food. Okay, most processed food has added sugar. In America, they did a survey of 600,000 processed foods in supermarkets. They found 82% of them had added sugar. Now, understand this. If you talk about a box of cornflakes. Cornflakes is already a carbohydrate food, yes? I'm saying to you that they add sugar to the cornflakes because it tastes nicer and kids want to eat more of them, so do you. So even in carbohydrate foods that are already carbohydrate, sugar is added in most processed foods. So processed foods are generally bad news. Real foods are generally not bad news. And the number 2 intervention is that we need to be eating more healthy fats. If you take carbohydrate out of a diet, you've got to add something back for energy and to regulate metabolism. We need more fat. Fat is not our enemy. Fat is our friend, as long as it's a naturally occurring fat. Vegetable oils, margarines, and trans fats are bad fats. They are manufactured. All right, but all of these animal fats, coconut fats, fishy fats, olive oil, avocados, natural resources of fat are all healthy, and we should be eating more of them. Okay. Often the question comes up, diabetics are very prone to kidney disease. If you eat a low-carb, higher-fat diet with lots of meat in it, you're going to be eating more protein. That is true. It generally amounts to a moderate protein, not a high protein. So the word says higher, not high. We don't advocate a high-protein diet for anybody. So is an increased protein intake a problem for diabetics? If their kidneys are fine, there is no evidence in any studies to date, including Westman's research, that a moderate protein intake upsets their kidneys at all. If, however, they've got pre-existing renal dysfunction, then they would need to be medically managed and protein levels might have to be manipulated. But the sort of overwhelming fear of protein and kidney disease is unfounded in the research. When we put someone onto a program of less than 25 grams of carbohydrate a day, they usually are entering what we call nutritional ketosis. That means that it's a physiological state, often associated with fasting or starvation or a carb-restricted diet. We do it naturally overnight anyway. When you don't eat from 7 p.m. till 5 a.m. the next morning, you effectively go into a bit of ketosis. That says that you produce some ketone bodies from your fat stores, and you use those for energy. Our brain and our hearts and our muscles love ketones for energy, so we produce those from fat. But when you have a carb-restricted program, you produce more and more of them, and they become the super fuel for your tissues. 75% of your brain's energy requirements on a carb-restricted program will be met by ketone bodies. You don't need glucose. And if you need a bit of extra glucose, you'll make it from protein. Okay. So nutritional ketosis is not ketoacidosis. That's very important. People hear about ketosis and they're freaking out in diabetes, because if a diabetic goes into ketoacidosis, especially a type 1, that's a life-threatening physiological, pathological condition, a very dangerous state which is caused by insulin deficiency in type 1 diabetics. Extremely high ketone levels, usually in type 1 diabetics. We're not talking about that. Nutritional ketosis is low level of ketones to moderate levels here, and ketoacidosis is very high levels of ketones produced in a severely pathological state when a type 1 diabetic hasn't got their insulin on board and they've eaten carbohydrate. They will go into ketoacidosis. Doesn't happen to type 2 diabetics. So am I going to have a heart attack as a diabetic? I've just said eat all this fat and don't eat all this carbohydrate. You're going to have a heart attack. Well, you're not going to have a heart attack because the risk of arterial disease is related to insulin, blood sugar, the funny cholesterols that occur as a result of that, and high fructose intake. So you're going to have a heart attack if you're diabetic because of elevated insulin and elevated sugar. Okay, not because of the fat intake. And I don't want you to look at the detail of the slide. I just wanted you to look at the yellow. Yellow is the changes in the risk factors for heart disease that occur when you're on a low carbohydrate diet. So all the ones that are bad for you, the yellow is going down much more than someone who's eating a low-fat diet. So yellow here says all the risk factors are going down more than they would on a high-fat diet. And the ones that we want to go up, like good cholesterol, are going up more than we see on a high-fat diet. So I just want you to look at the picture. The picture tells you that the yellow lines are telling you that on a low-carbohydrate, high-fat diet, cardiac risk factors improve substantially. Okay. Which might be contrary to what you might have thought. So, in closing, in terms of type 2 diabetes, a very low carbohydrate, high fat, ketogenic diet is a very effective preventive lifestyle strategy to counter early carbohydrate resistance, where people notice they put on a lot of weight, a lot of belly fat. It will prevent and treat metabolic syndrome, and it will reduce the number of people who actually progress to diabetes. So people who know they have a tendency towards diabetes, because you've got a family history, and you've noticed with your family history, you get fat, much fatter than your mates who eat the same food as you do, then a low-carbohydrate diet is a very good idea as a preventive lifestyle strategy, along with exercise. Exercise is a good intervention, but it's not the sole intervention that will help people to lose weight. It's a very poor weight loss tool. Very good for maintaining levels of insulin sensitivity in your muscles. So exercise is a very good thing to do preventatively. As a therapeutic intervention, it's the cure for diabetes. A very low carbohydrate, high fat ketogenic diet is without doubt the cure for diabetes. It will cure diabetes well, it will make a huge difference to obesity, it will cure metabolic syndrome, and it will cure diabetes. And that we now know. Right, before I talk about those, what's your name? Tammy. Type 1 diabetes, for those in the audience, and I mentioned before, type 1 diabetes is a disease or a condition where the pancreas fails to produce enough insulin. Commonly occurs in childhood, but can affect people in adulthood. It's thought to be a complication of viral infections or some other form of autoimmune disorder that knocks out the pancreas, and you have no or very little insulin. So type 1 diabetic who eats carbohydrate in their diet has no metabolic way of managing or handling the blood sugars in their system. So all type 1 diabetics need to take insulin, to give themselves insulin to manage the carb in their diet. But again, one of the deficiencies in the old conventional management system has been that we've said to you, listen, you can eat carb, but then you must regulate your insulin against your carbohydrate. Okay? So you carb count. If I had that much carb, I give myself that much insulin. The problem is, if you track type 1 diabetics, over time, the more insulin they give themselves over time, the more complications of diabetes they develop that mimic the complications of type 2 diabetes. They become fat. They develop arterial disease. They become blind. They get circulatory blockage in their legs. They develop the same complications that the type 2 diabetics develop. So we now believe, this is the new thought leaders, that the more insulin you take as a type 1 diabetic, you become insulin resistant. And over time, you start to become someone with type 1 diabetes with an embedded type 2 diabetes matrix as well. So there is definitively a role in type 1 diabetics for low carbohydrate nutrition programs. Because if you reduce your carbohydrate, you reduce your insulin demand. If you reduce your insulin demand, there is less chance of you suffering the insulin toxicity which type 1 diabetics eventually do develop, which is really interesting. Okay, you will always need insulin. Our role in type 2 diabetics is to get their insulin, if they're taking it as a medication, and get rid of it. For you, you'll require it because you have none. So there is definitively a role. Okay, and this research, some of it has been done, some of it's going forward, but the theory, if you like, is clear and sound. Now, there's a couple of interesting things. We talk about carbohydrates becoming sugar and requiring insulin. Protein also requires insulin. Protein requires about 50% of the insulin the carbohydrate does. So one of the issues for type 1 diabetics is you've got to be careful about eating a lot of lean protein. Okay, so lean protein is often seen as a bit of a neutral. In fact, it isn't. So it's better to eat fatty protein than lean protein. It's better to eat rump steak with a nice big fat on it than fillet steak, because that fillet steak will demand an insulin response, an insulin treatment. Okay, so there's quite a lot of work being done now by a lady in Sydney who has come up with what's called an insulin index, and she's looked at foods and how they stimulate insulin, what the insulin requirement is, because it's very helpful for you to know that certain foods don't always stimulate insulin directly proportionally to their carbohydrate content. The protein content also makes a difference. Okay, so that's something we can chat about after, and actually there's a whole chapter in my book on that for type 1 diabetics. But low carbohydrate nutrition is relevant because it will reduce your insulin demand, and in time will reduce your risks of the complications of diabetes which are no different to the type 2. Okay. Right. What I wanted to tell you is in terms of the mechanics of low-carbohydrate nutrition, it's very good to have resources. When my book comes out, it'll be a good resource. There are 2 fantastic books currently around. There's Tim Noakes' book, The Real Meal Revolution, which some of you might have heard of. There's a book by, and I'm not sure who the Afrikaans-speaking people. Give me this name. And what's the first name? Ina Renisa, yeah. It's called Low Carb is Lekker. It's a fantastic cookery book for low-carb nutrition. And there's one written by Monique Leroux Forsland, who's actually a Cape Town girl who married a Swedish guy and lives in Sweden now, called Low Carb Living for Families. These are great resources for how to cook and make food in the low-carb way. In fact, we're bringing them in, and Linda does bring them in on order now so that people have got them available. So if you're interested, have a chat with Linda. We bring them in batches. I can highly recommend these if you wish to have tools. How do you do it? What do you make? How do you make low-carb bread? How do you make low-carb pancakes? Okay, these are fantastic tools if you have an interest in following that. So that's something I wanted to show you. And I just wanted to thank you for listening and ask as many questions as you would like. And I would like to tell you that we have low-carbohydrate snacks on us tonight, provided by Kim and Jenny. And Alana, are you there as well? All from Tree of Life. And they're going to be making low-carb foodstuffs. That's their new business, and their cards will be there. So if you don't want to make it at home and you want to buy low-carb bread and low-carb crackers and low-carb chocolate brownies, they're the guys to talk to, and they've got some lovely snacks there for you to sample on your way out. So please go and do that and have some food and take their cards away. Otherwise, I have to eat it all, and then I'm going to feel a bit full. Okay, so any questions, let's take them. Thank you very much for your attention. Anything I can answer?